recording here. So over to you.
Okay, hello everyone. Good morning, good afternoon, good evening, and welcome to the Vector-borne disease session 5 of the Epi Response to the Climate and Health Crisis, a virtual webinar series brought to you behalf the TEPHINET, the Global Consortium on Climate and Health Education at Columbia University, and the Public Health Institute of the World. My name is Elizabeth Estacio. I am a researcher from Argentina. I belong to the National Scientific and Technological Research Council, known as CONICET, and I am a National Geographic explorer. I'm working with vectors and vector-borne disease since 2005. My team research centers on understanding how environment drives mosquito population of health concern and emerging disease by developing spatial and temporal models to study process underlying the emergence, spread, and control of disease, of infection disease, and the relation with climatic and environmental factors through remote sensing and meteorological data. Nowadays, as National Geographic Explorer with my team, we are studying mosquitoes biodiversity, which include vector mosquitoes and the effect related to urban heat island effect in Córdoba city, a temperate area of central Argentina. It is my honor to be here with you today and moderate this session. So, as many of you know, the impact of climate change are widespread, rapid, and are intensifying. Climate change is leading to increase in global temperature and erratic precipitation patterns, both of which are contributing to the expansion of several pathogens and vectors related to respective vector-borne disease. For example, the distribution of parvovirus disease transmission is expanding from the tropic and subtropic into temperate regions worldwide. Like in Argentina, in the central temperate area of the country that has been experiencing the emergence of dengue virus transmitted by mosquito Aedes aegypti since 2009, when autochthonous transmission of the virus was first recorded in several cities like Córdoba, where I'm from. So today we will be hearing from Dr. Catalina Ramirez Hernandez. She is an epidemiologist and Master of Management and Health Service and Field Epidemiology in Costa Rica. She's part of the National Costa Rican team of the Field Epidemiology Training Program. She's a National Coordinate Emergency Disease. She works in applied epidemiology training programs in epidemiological research, investigating and responding to epidemics and implementing community-based interventions. Manford Malamia, he graduated at Malawi College of Health Science on Environmental Health. He experienced coordinating programs like the food safety and hygiene and vector control. Since 2016, and nowadays he coordinates the integrated disease surveillance and response on the area of control disease. And Dr. Eduardo Samo-Gudo, he's a General Director Deputy of the National Institute of Health in Mozambique. He's a Bachelor in Medicine and a PhD in Immunology and Virology. He also completed Senior Postdoc Fellowship on Emerging Infection Disease through European Foundation Initiative for Africa Research into neglect tropical disease in Germany. Since 2015, Dr. Gudo is leading research project on climate and health and co-leading effort to establish of climate and health observatory in Mozambique. I encourage you to put any question into the Q&A section, and we will be back with all questions at the end of all presentations. Remember, please, the questions in the Q&A should be specifically for the panelists. It is my pleasure to introduce our first panelist today, Dr. Catalina Ramirez Hernandez. Catalina, your audio is off.
Okay. I'm sorry. Buenos días, buenas tardes y bueno, aquí estamos para hacer para compartir nuestra experiencia en relación a las enfermedades vectoriales en medio de nuestra realidad que es el cambio climático. Siguiente. Next. Okay. Bueno, considerando que la enfermedad es transmitida por los vectores y que genera gran cantidad de personas enfermas, se considera pues que es una enfermedad de mucha importancia a nivel mundial. Y su transmisión está basada o tiene múltiples factores que van relacionados desde la extensa infestación vectorial, insuficientes redes suplidoras de agua, el incremento de los depósitos de agua desechables o no utilizados, inadecuada disposición de los desechos sólidos, migración poblacional y dentro de la migración puede haber migración por razones laborales o simplemente la migración recreativa. Además del incremento de la población a nivel de las áreas urbanas y el crecimiento de la densidad poblacional en las áreas urbanas y por supuesto lo que nos tiene aquí que es todo lo relacionado al cambio climático. Next. En Costa Rica se introdujo la enfermedad desde 1993. Antes de esa época no teníamos enfermedad, dado que se había extinguido de manera bastante ardua previo a ese periodo el vector. Luego en el 93 ingresó en Costa Rica por una zona costera llamada Punta Arenas y desde entonces se ha extendido a nivel nacional con una progresión bastante interesante porque permaneció siempre en áreas de este tipo costeras y desde esa fecha pues hemos tenido diferentes oportunidades de brotes, un año con un brote de dengue grave bastante importante donde tuvimos aunque muy baja mortalidad a nivel internacional, pues para nosotros como país fue de muy alta mortalidad. Esto no ha sido al azar, se han localizado justamente en las zonas de predominio costero con las características que al vector le han sido bastantes amigables y ideales para que él permanezca y se reproduzca en sus inicios. Y siempre tuvimos la estacionalidad regular entre las semanas 18 y 29, eso quiere decir entre abril y julio, y una estacionalidad de ese tipo y una periodicidad de cada 2 años, pues teníamos una situación de brote bastante importante. Y esto coincide con el inicio del incremento de la lluvia, siendo ese momento nuestra época lluviosa o de verano cuando teníamos bien definidas esas dos estaciones. Siguiente, next. Nosotros como país, cerca del 2005, nuestra unidad de epidemiología hizo un estudio bastante importante con relación a este tema, únicamente refiriéndose a la zona donde se introdujo la enfermedad en los años 90. Y ahí se pudo demostrar cómo a través del tiempo, desde los 90 hasta el 2004, se afectaba por la cantidad de precipitación que teníamos y cómo fue variando eso en el tiempo. Entonces, este fue el gráfico donde se pueden ver en gris claro la cantidad de precipitaciones que se presentaron en cada año y así en gris oscuro cómo se comportaba la enfermedad en ese momento. Next. Igualmente en ese estudio se ve cómo en el tiempo hay una variación del pico, o sea, siempre iniciando aproximadamente en el mismo momento, hasta el 2004, que está hecho el estudio, siempre iniciando en el mismo momento y acabando en el mismo momento con un pico donde se mantiene. Y la duración es la que va variando. En general, en promedio, pues se tiene lo que se esperó y se describió en el gráfico anterior. Next. ¿Qué hacíamos en ese momento? En ese momento, con relación al control y prevención, era una estrategia muy dirigida, muy localizada en las zonas donde habían brotes, principalmente en las ciudades costeras del Atlántico y las costeras del Pacífico. Se formó y se capacitó mucho el personal porque era la primera vez que teníamos la enfermedad, tanto en control vectorial como en manejo clínico. Se hicieron supervisiones muy exhaustas y prolongadas para verificar que tanto el personal de manejo de vectores como el personal de salud nuestro pues estuviera realizando las actividades necesarias para hacer el control. Se hacían cercos epidemiológicos cerca de 500 metros a la redonda, utilizando también el perifoneo, y el objetivo era captar pacientes con fiebre. En un inicio nosotros hacíamos pues una vigilancia de febriles y posterior en el tiempo también esto fue haciéndose un poco más específico, cumpliendo con una definición de caso. En ese momento se hacía fumigación localizada y control de formas inmaduras, justo en el punto donde estaba el brote, y también se hacía trabajo intensificado con líderes comunales para hacer las campañas de recolección de desechos no tradicionales y también de una manera preventiva que nos ayudaran con el tipo de síntomas que la población necesitaba saber para acudir a los servicios de salud. Asimismo, se trabajaron con municipalidades y organizaciones adicionales para que nos apoyaran en este proceso. Next. Y aquí un gráfico muy simple donde la gestión ambiental para controlar el mosquito dengue en esa época era muy localizado. Una casa alrededor de la cuadra, se miraban los alrededores dentro de la casa, alcantarillado, la recolección de basura, se miraban los lotes vacíos, pero muy localizado, no había ningún trabajo extenso geográficamente porque no era la realidad que vivíamos. Next. ¿Qué ha pasado con el cambio climático y las enfermedades vectoriales? Hay mucho que hablar alrededor de esto porque el cambio climático no solamente afecta los vectores y los roedores, sino también otras enfermedades que pueden ser afectadas, sabiendo que el cambio climático pues es una alteración de varios factores. Next. De varios factores en el ambiente que afectan el equilibrio en la biología, ciclos vitales y también en la distribución geográfica del vector que tengamos en consideración. En este momento sería, pues, en el caso de nosotros que estoy presentándole lo que es dengue y malaria. Entonces, conociendo esto, se pueden generar se puede esperar cualquier tipo de comportamiento de distribución o perfil epidemiológico de las enfermedades si está siendo afectada por el cambio climático. Los vectores que nos pues nos importan en este momento, pues dependen fuertemente de las variables climáticas, sobre todo temperatura y precipitaciones. El cambio pues también genera cambios de patrón de estacionalidad, de periodicidad, no solamente la estacionalidad, sino la periodicidad. Y desde el punto de vista de abordaje, el cambio climático ha venido a ponernos en una posición de visión muchísimo más amplia, donde no solamente se vea la salud humana por sí misma, sino que tenga que ya verse con una visión de una sola salud, donde se integre la salud animal, el ambiente y la salud humana para hacer un mejor trabajo y tener un mejor impacto a nivel de las poblaciones. Next. Básicamente esto es lo que, de forma gráfica, esto es lo que produce el cambio climático en un ciclo de vector. Hay altas temperaturas, pues favorece, si estamos en el lado izquierdo del dibujo, pues vamos a tener un lado del cambio climático que es cuando hay sequía y hay altas temperaturas, cantidad de precipitaciones y por supuesto que va a incidir en el comportamiento del vector, alargándolo o acortándolo desde sus formas inmaduras. Igualmente, si hay un aumento de las precipitaciones, hay inundaciones, pues igual en ese momento pues tendríamos cambios vectoriales donde estaría facilitándose la transmisión de las enfermedades. Siguiente. Bueno, me disculpan si se ve un poco borroso, es parte de la imagen. Este es nuestro país, dividido pues en las 7 provincias. Vamos a ver. Del lado derecho de la pantalla podemos ver todas las provincias que estamos la morada y la celeste, que son las que son ciudades costeras, y tenemos otra amplia costa en el Pacífico que va desde el norte hasta el sur, y es en la zona donde se han siempre, por aquí en el centro, fue por donde se introdujo la enfermedad y ha afectado siempre esta zona. Predominantemente son zonas que nos han aportado gran cantidad de casos a través del tiempo, y también a través del tiempo se han ido involucrando otras provincias inclusive que no son costeras ni de baja altura, sino que ha afectado hasta el centro del país, que bueno, tiene alturas más por encima de los 600 metros sobre el nivel del mar. Siguiente. Aquí podemos observar, esto sí es algo bastante reciente que se hizo, cómo las precipitaciones eran o son en este momento, ¿verdad? Traté de buscar las precipitaciones más antes del 2020, y pues en ese momento no era como tan necesario, ni se veía como tan necesario hacer una vigilancia de la distribución de las precipitaciones o del clima para tenerlos actualizados. Y al día de hoy, pues no hay una cobertura completa del país donde se pueda vincular directamente las precipitaciones en términos individuales o geográficamente con la ocurrencia de casos. Entonces, este es nuestro país con relación a las precipitaciones. Lo más azul es donde vamos a tener mayor cantidad de lluvias, y así sucesivamente hasta el colorcito más amarillo, que comienzan al revés, la mayor cantidad de precipitaciones, y aquí la menor cantidad, pero se va en una degradación. ¿Qué sucede o qué se espera en una proyección que ellos hicieron? el Instituto Meteorológico, porque esto es cortesía de un estudio que hizo el Instituto Meteorológico nuestro, que ellos han ido proyectando cómo va a ser nuestro país hasta el 2100, por ejemplo. Entonces, están mirando nuestro comportamiento de precipitaciones, concentrándose principalmente en las zonas donde va a haber más precipitaciones azules y en el resto en forma gradual donde vamos a perder las precipitaciones. Ya les voy a decir por qué esto no es importante. Siguiente, next. Aquí, con respecto a la temperatura, pues lo que vemos es cómo se ha ido incrementando la temperatura a través del tiempo, considerando estos datos desde el 2010 hasta el 2100 en una proyección donde se incrementa la temperatura, aunque se mire muy poquito, con 0.034 grados centígrados cada año, esta variación es suficiente para impactar el comportamiento de la enfermedad, las enfermedades vectoriales o de roedores. Siguiente. Aquí pasó algo. No sé, pero mi gráfico estaba bien cuando lo puse. Este es un gráfico donde la anterior, ajá, no, debe ser algo de formato posiblemente, pero es simple. Aquí abajo vamos a tener en cada sección, ¿verdad? De rayitas más largas, los años, y en las líneas vamos a tener el comportamiento de 3 enfermedades, que es el dengue, la chikungunya y el Zika. Esto estamos hablando de integrando la enfermedad para ver cómo era el comportamiento, a ver si se iba a presentar de igual forma. Y pues observamos en este momento que comenzó en el 2017, si la memoria no me falla, el comportamiento lo esperado para dengue y para chikungunya, pero para Zika pues tuvimos un comportamiento diferente y se bajaron los casos y no presenta ninguna estacionalidad. De este comportamiento de las dos enfermedades, la verde y la azul, que es Zika y chikungunya, pues sí tuvieron su estacionalidad en el momento de la introducción y muy semejante a lo que era esperado, que es el dengue. Aquí el dengue pues se nota donde cumple con la estacionalidad que les mencioné y la periodicidad que ya ha sido afectada, donde ya no se cumplía con lo esperado, que era cada 2 años un incremento de los casos, sino que ya comienza a presentarse casos en cualquier año, no necesariamente cada 2 años. Hemos tenido hasta 3 o 4 años, dependiendo de la situación, donde no se presentan la cantidad esperada, aunque tengamos lluvias o no. Y obviamente que pues el patrón de lluvias ha sido alterado por el cambio climático, igual las temperaturas. Y esto nos lleva a observar cerca del 2013 y 14, donde el 2013 se desplaza la época epidémica casi que hasta diciembre, casi hasta final de año, y ahí continúa. Esto nosotros lo consideramos que esto es una subnotificación por el personal que en estas épocas pues sale a vacaciones y pues, siempre observamos un descenso considerable que no es propio de la realidad, sino por cambio de personal. Pero esto se siguió ocurriendo como parte de lo que se inició en el 2013, continúa en el 2014 en la época en la época seca. Nosotros teníamos y tenemos 2 estaciones, que es la época seca o verano, que que iba pues de mayo a junio, y una época lluviosa que abarcaba pues de el resto de los meses. Eran de 6 meses, era semestral. Así lo teníamos bien definido. El siguiente, perdón. Aquí podemos ver un poquito más la distribución de estos casos, incluyendo a este año, ¿verdad? Por semana epidemiológica. Tenemos la distribución del 2019, 20 y 21. Y en negro, pues lo que llevábamos en este momento de los registros de dengue en nuestro país. Aquí se logra observar que de acuerdo a la mediana de los casos del 2017 al 2021, pues todas coinciden en los meses esperados. Más sin embargo, en el 2019, que es esta la naranjada, en el 2018, que es esta blanquita, y en el 2020, que es esta, pues no se comportaron de la misma manera que se esperaba, a diferencia del 19 y del 21. ¿Qué pasó con este año? Este año vamos bordeando lo que es lo esperado sin salirnos, inclusive muy parecido a lo que fueron los años del 2018 y 2020. Y veremos cómo terminamos, porque hasta este momento estamos observando la circulación, o tal vez estamos poniendo atención a la circulación de la enfermedad en este momento. Las pandemias siempre afectan, y puede ser que la notificación haya sido afectada por la pandemia, que nuestro personal esté muy programado en enfermedades respiratorias más que vectoriales. Siguiente. Uy, no sé qué pasó. Igualmente, debe ser un problema de formato. Aquí lo que quería mostrarles es que, bueno, nosotros estamos divididos en 7 regiones y provincias, donde se puede observar en la tabla, que es lo mismo del gráfico, y es más fácil explicarle la tabla, donde se ve que el Caribe sigue siendo una de las zonas donde aporta gran cantidad de casos. Esto es la distribución de este año. Es reciente, llevamos 4.638 casos, pero siempre habíamos tenido la otra parte de la zona costera, que es el Pacífico Central, y la otra parte de la costa, que es la Chorotega. Siempre estaba en nuestros primeros lugares. Para este año tenemos una zona que no es costera, sino que es fronteriza, que sí se observa, pues es de las que tienen menor cantidad se observaba que tenía menor cantidad de lluvias, y una región que es la tercera, que es una región central, del centro se ubica geográficamente en un área del centro del país, tiene una zona que podría ser favorecedora de la transmisión de la enfermedad, y en este momento tenemos brote en esta zona central de nuestro país, ubicándose principalmente en la zona que siempre produce casos, que no tiene playa, no tiene ningún otro factor más que un poquito la diferencia sobre el nivel del mar.
Catalina,
Sí, next.
tenés 5 minutos, te quedan.
Sí, next. Aquí vemos la distribución de los casos por serotipo. Aquí se puede observar cómo se han concentrado en la zona del Atlántico y ya no tanto en la zona del Pacífico, y esto es por el cambio climático. Estamos teniendo más lluvias de este lado, a pesar de que nos afecta a todo el país, pues las precipitaciones varían según la zona, pero sí hay una alta predominancia de la sequía en la zona del Pacífico. Next. Esto era con relación a dengue. lo que les acabo de hablar. Con relación a malaria, es una enfermedad que no la teníamos de manera autóctona, sino hasta el 2016 que tuvo una introducción. Y desde ese momento, pues, no hemos podido controlarla y estamos dentro de la estrategia IREM, que es de eliminación, es una iniciativa regional de eliminación de la malaria para el 2025. Pero nosotros estamos teniendo casos desde el 2016 en este comportamiento donde no hay estacionalidad, donde no hay periodicidad evidente, pero sí la presencia de la enfermedad de manera activa e instaurada. Next. Nuestra distribución está ubicada aquí, donde también esperaríamos que estuviera la presencia de dengue, y eso es lo que está ocurriendo. Está la región Huetar Norte, que les mencioné que era fronteriza, como ven, no tiene ninguna relación directa con las zonas costeras que nosotros esperábamos, pero de aquí principalmente es donde están ocurriendo los casos de malaria, con alguna presencia en la zona montañosa, obviamente, y en zonas específicas costeras. Next. Nosotros a partir de ahí, pues estratificamos para ambas enfermedades el país. El dengue estaba estratificado en cuatro estratos, ¿verdad? Y va relacionado principalmente si tiene presencia o no tiene presencia del vector. En el caso de malaria también se hizo una estratificación relacionada a la vulnerabilidad y receptividad que se pueda tener en el país para los casos. Los puntos rojos son los lugares críticos donde podríamos tener casos, y los verdes claros y verdes oscuros donde posiblemente podrían encontrar algún caso, y lo azul lo que no son zonas que no son posibles por sus características ambientales que aparezca un caso autóctono o se instaure la transmisión. Siguiente. Esta es ya casi creo que la última dentro de las actividades de control actuales que hacemos, teniendo ya el efecto del cambio climático expresándose en su estación relacionada al efecto de la niña y el niño, pues hemos tenido que ampliar o extender nuestras actividades de control y prevención. Una ha sido la introducción y la incorporación realmente en iniciativas que nos ayuden a poder eliminar principalmente la malaria. El dengue ha sido difícil de hacerlo. Llevamos cerca de 30 años de tener la enfermedad en el país. Capacitación y formación del personal en control de vectores, se tuvo que retomar cómo se controlaba la malaria, y en términos de dengue, pues se tuvo que cambiar de una estrategia puntual a una estrategia de bloqueo y de contención para ir atendiendo concéntricamente los anillos exteriores en una rutina permanente. Capacitación en el manejo clínico de las enfermedades, la supervisión se ha intensificado, y por supuesto que la división y estratificación del país fue parte de la estrategia para poder atender los puntos críticos y optimizar los recursos que tiene el país. El siguiente. Next. Se ha trabajado también en fortalecer en una sola salud, ¿verdad? Hemos integrado actores de salud animal y otros relacionados al ambiente, porque tenemos pues ministerios relacionados directamente con la salud animal y con los aspectos ambientales. Educativamente hablando, pues la institución que presta mayor servicios de salud instauró una campaña de prevención y de educación a la población que se basa en los 13 mandamientos, la denominamos así, porque habla de cómo reciclar, reutilizar, etcétera, etcétera, volcar, agujerear los depósitos que son inservibles y cómo tratar los que son necesarios para la ingestión. Y además, jornadas mensuales del último viernes de cada mes donde se hace más fuerte la educación y la prevención para las poblaciones. Y por supuesto que como es parte del quehacer nuestros de los FTPs, pues es el abordaje de los brotes de manera intensa y la participación en acompañamiento en los niveles locales, que son los que están teniendo el problema de los casos, para darles ayuda y soporte de cómo estratificar o cómo priorizar algunas zonas. Siguiente. Next. Eso sería todo lo que yo podría compartirles en este momento de nuestro país rápidamente en los 15 minutitos que tenemos asignados. Gracias.
Thank you. I encourage everyone to put any question into the Q&A section, and we will be back at the end of the presentations. Now, it is a pleasure to introduce our second panelist, Manford Malemia. Manford, are you there? Okay, maybe Manford is having trouble with the audio. We'll keep going with our next panelist, Dr. Eduardo Samagudo. Welcome, Eduardo. If you want to go ahead and do your presentation.
Thank you. So should I share?
Welcome.
Okay, thank you. Okay, thank you for sharing slides. So. Yes, good morning, good afternoon, everyone. So I will share the experience in Mozambique with the climate change and in the context of the Vector-borne disease in Mozambique. My presentation is more based on our conversation on the prior interaction by email that will be focused on more practical aspects, and then on the also in terms of the education, what experience Mozambique has in terms of incorporating climate and health within training program in Mozambique with emphasis for the FETP. Next slide. So this is the outline of my presentation. Next. So this is to highlight that Mozambique is a country with one of the highest vulnerability to extreme climate events. So in the climate risk index from 2018 in Mozambique, indeed Mozambique was ranked among the top 3 countries that are more vulnerable to extreme climate events. So just remember that Mozambique is this country that there are 2 countries. It's Mozambique with red, Mozambique and Madagascar. Madagascar is the island. Mozambique is the country that is over the coast that within this red dash circle. So you can see Mozambique is over the Indian Ocean, is over the coast. We have 2,500 kilometers over the coast. And then just remember that the Indian Ocean is the temperature of the Indian Ocean is rising. Indeed, when you look at all oceans, the Indian Pacific and then Atlantic, so the Indian Ocean is the one that is the temperature of the water is rising more rapidly. So if just remember that is the rise of the temperature of the ocean is part of the process for the generation of to generate and to create cyclones. So the more warm the water in the ocean is, the higher is the risk and the frequency of the cyclone that comes from the ocean. So the cyclones, they are generated from the ocean and then they go into the continents. So and then the frequency of the same climate event has been increasing in Mozambique indeed. And then the future projections show that this will continue to increase, not only cyclones, but heavy rains and floods and droughts. So in the bottom, you can see is a manuscript that was recently published by our group that describes what has been the impact of extreme climate events in Mozambique in different perspectives. So, and then the graph is the numbers not clear, yeah, but it's just to show that there is a high impact of those extreme climate events. So you can see the impact of floods in terms of the affected population and frequency of events. So, and then the same for the cyclone and for the drought. So you can see by the numbers in terms of the frequency of events and the number of people that are affected that are quite significant. Next. So this slide is part of our experience during Idai cyclone. So I have a slide more upfront that describes much better in terms of the number of the Idai cyclone. So this is a picture that was got at the time. I think that was got 2 days after the cyclone hit the Mozambique 2018. Just remember that is considered one of the most severe cyclones that has hit the sub-Saharan Africa and the South Hemisphere in the recent stories. So this is just to describe the multiple impact that this has. So this is nothing new for you. And then that to highlight that is not only the direct impact of those events that cause outbreak of the infectious disease, but indeed you have to consider that there are other multiple impacts that has that also have an indirect impact on the negative damage that the extreme climate event caused on the infectious disease. So the topic here today is for the vector-borne disease. So when you have that kind of events, the risk of the outbreaks of vector-borne disease, they rise. Next slide. I cannot see I am still here on yeah, okay, thank you. So we in Mozambique, we have established sentinel sites because in Mozambique, testing for the vector-borne vector-transmitted disease, such as arbovirus and others, they are not part of the DHSA2. They are not part of the health management information system, the routine. So we don't test routinely for those diseases in Mozambique because of lack of resource. So if you want to get information on the trend, the epidemiology, the burden, and determinants and other aspects, and you want to monitor the trend, so you have to do either research or a kind of research or and survey or sentinel sites. So we have established sentinel sites across the country in both in the northern region, the central and the south region. In those sentinel sites, what we do is we prospectively collect sample from febrile patients. We are doing this for around 8 years that we have begun establishing and collecting prospective those samples. And this has allowed us to track the trend and the burden of those vector-borne disease in countries. So our institute it's a public health institute, so we are a full autonomous institute, but we report to the Ministry of Health. So we have a nice collaboration with the Ministry of Health, with the provincial authority that facilitate the implementation of those Sentinel surveillance. I will say that data from this Sentinel sites represent around 90–95% of evidence that we have in Mozambique, the recent information of the last 8 years on the occurrence of those diseases. Next slide. So these are some of the field work. Example, this is related with the entomological component. So we also collect environmental samples to get adult mosquitoes, Aedes mosquitoes, but also the larvae in the water. So these are some of our team searching for our larvae of Aedes mosquito. Next slide. So in the beginning, for a long time, because all the reference labs, they sit within our institute. And then we have the National Reference Lab for the entomology. For many decades and historical, our entomology has focused on the Anopheles basically because of malaria. So as you know, Mozambique is part of the top 4 countries in the world with the highest number of malaria cases. Just to have an example, Mozambique each year reports around 11 cases of malaria. Well, and recently we have expanded our focus to include also surveillance and research on the vector for arbovirus. In this case, I'm talking about Aedes mosquito. So this is an example. So we have been able to train the team. And then in those sentinel sites that I mentioned, also we collect a sample for entomological characterization of the vector. Next slide. These are some of the outputs. So in the left side of the slide, it's the first ever mapping that has been conducted in Mozambique for the Aedes. So we went to Mozambique is a country with 11 provinces and 160 districts. So those admin division that you can see in the map, Mozambique map is in the lower side. So we have Africa, and then we have Mozambique. Are the admin division for the district. So we have 160 districts. So we went to 32 districts and we collect environmental samples, adult mosquito larvae on those, and we were able. You can see that those districts that I highlighted in pink are those that where we have been able to sample. We found high density of mosquitoes in all diseases that were searched. This is dominated by the Aedes aegypti, but there is in one disease we found the Aedes albopictus. So in the right side is part of our surveillance that we have been able to identify the vector, the species that transmits the yellow fever. So this is part of genetic sequencing of Aedes in Mozambique. Next slide. So additional findings. So in the left side, is related with the flood. So as I said, we are doing this also looking into impact of our relationship with flooding, with the same climate events. So in left side, it's evidence on increase of cases of Rift Valley fever based on serological evaluation that based on samples that were collected during and after the having rain and flood. There was a flood in Mozambique in 2013. We were there. We got samples that around those times, and then we tested. We found out that there was increased in Rift Valley fever. It's an arbovirus. On the right-hand side of the slide, it's the mapping, or is the historical map over the 9 years from 2009 to 2015. So are seven years, yeah. And then these are serum from febrile children. So we test for chikungunya. You can see, so in the The green are the districts where we have sample. We got sample from those children, so serum samples. And then the red are the districts where we found samples that were positive for that. So as you can see, the transmission of the occurrence of chikungunya is across the country. And then there are a trend toward an increase in terms of the frequency of chikungunya in Mozambique. That we believe is correlated, is related with the climate change. Next slide. So this is the experience of FETP. So now I am moving into the role of the FETP. So in those pictures, you can see FETP trainees and some indeed are also graduates from FETP. So this is the 2 years training program. That trainees and graduates from the 2-year training program of FETP, in Mozambique FETP, after 2 years, you get master level also. It's equivalent to master level FETP in Mozambique, the 2-year program, and then peace. And then this is show how they have been really very critical in response to out the Idai. This is the Idai out cyclone that hit Mozambique in 2019. They have been able in several components of the surveillance and then response and monitoring of the impact of Idai cyclone. So building laboratory surveillance, early warning system, outbreak investigation. Indeed, the first during the cyclone, in the aftermath of that cyclone, there was a largest cholera outbreak. Indeed, who investigate, and we were critical for the rapid identification where the FETP trainee and graduates. Next slide. So this is the Idai cyclone, the impact, as you can see, in terms of the number of people that have been affected, more than 1 million. You can see in terms of accommodation center, more than 100 accommodation center, and then death, more than 600 deaths that were reported, that were identified and reported as a consequence. So it gives you the really huge impact of that cyclone. Next slide. And then this is more on the picture on the role of FSB. So different pieces. So you can see them in the field. You can see they doing the analysis of logbooks, collecting data from logbooks, and doing a lot of data analysis. When you have a cyclone at that magnitude, definitely you have to have a real-time surveillance system. So you have to get data in real time, and then everything was destroyed. You can imagine how can you build a real-time surveillance system in a context where we have no electricity, no roads, no laboratory, no phone connection, all mobile phone, they were off. Next slide. So this is some, just to have an idea. So how do you can respond to an outbreak with all those difficulties? You have no health facility, no logbooks, bridge destroyed, road destroyed, no electricity, and a lot of people in accommodation. So I could spend one day just trying to explain how that was hard at that time to deal. So how can you have a real-time surveillance system in that context? Next slide. So, and then we learned a lot with this Idai cyclone. We did research with the evaluation. We collect experience that is being critical to change our mind in terms of the urgent need to incorporate into the FETP the component of climate change, and then the impact of the climate change as well. And then because of the experience we had, so during Idai cyclone, they have to learn in the field. And then we compile all those experience. So experience with the Sentinel surveillance, with our surveillance, experience with Idai, And we come up, we sit in the room, and then for 1 week, we try to develop a module. And then this module was incorporated into FETP. So the current cohort of students of FETP, they have one module that focuses on the climate and health, includes also one health and zoonotic disease. So those are some of the manuscripts that has been published with collaboration of the FETP. Next slide. And then, as I said, this is what we are doing. So, and then indeed, this module is not being incorporated only in the FETP program. We're incorporating other 2 postgraduate training programs in a Master of Public Health and then medical specialization on that is only for medical doctors in public health. So we try to incorporate the module of One Health and climate change into the main curriculum for the postgrad training of epidemiologists or public health specialists in the country. Next slide. This is the module. So I'm not sure if we have shared, but I think we have shared what is the content of that model. So we go from the basics. What is climate change? What is climate variability? How do you interpret different information in terms of the weather, winds, the speed of the wind, and other components? And we go also into the impact of the extreme climate events, the short, long, mid, and long-term impact. So the role of establishing rapidly a surveillance system at the aftermath of those extreme climate events. So we believe that with that, we are more prepared and to respond to the extreme climate event, comparing with the previous graduates from the previous course. Next slide. So this is the FETP Mozambique was launched in 2008, and then since that until today, so we had 4 cohorts. So there is a test that in the bottom of this rectangle that is not that it was lost to a while. But we are now in the 5th cohort that is just coming to the end. And then this is the one that benefit of this module of climate and health. The other previous one, they have not benefit of that. And then from now on, so they have this module. So we did not have at that time an example of the module of climate change, climate and health to rely on, to make copy and paste. So you have to build our one. So we have to build based on what that means. Not a perfect module. We are still improving all the time this module from year to year. We are making change based on new knowledge, new experience on the climate and health. And then we have account with collaboration with the meteorological institutes. They have been really grateful. And then they help us with the modules, with the preparations, with the water resource authorities in Mozambique, and then with some of our international collaboration that we had to try to compile that module. So next slide. So this is the perspective that we have in terms of climate and change. So implementation of the research agenda that is coming to the end. We have drafted the climate agenda on climate and health. So continue with the monitoring of the impact of the climate on health. We conducted the VNA in Mozambique, and then we developed also the HNAP, so VNA Vulnerability Assessment. And then that was conducted 3 years ago, and then now the HNAP, the Health National Adaptation Plan, has been completed, is now under the process of being approved by the Minister of Health. Next slide. I think I've just come to end of my. Thank you for your attention.
Thank you, Eduardo. Great presentation. And now we are going to go to our next Manfor Malemia. Are you there? We welcome you to start your presentation. I think we are having audio problems with Manford. Maybe the internet connection.
Manford, are you still there? Do you want to maybe try the audio one more time now that we've turned your video off and see if the connection problems have resolved? Okay. Elizabeth, it seems like Manford might be having connection issues. I see that he just left and maybe he's going to try to rejoin. But let's see what happens. I think maybe we can move to Q&A, and if he comes back, we can try to see if we could get his connection going again. But for everyone who is still here, we will try to send out Manford's slides after the presentation so that you will still have access to those. And we will send out the other presenters' slides as well.
Okay, thank you to everyone for being here, and thank you for the presentations. They were very good to hear the experience of each of you in your countries. We have a lot of questions. We'll try to answer the main ones or the main themes. The first ones are for Catalina. I don't know, Catalina, if you're going to answer in Spanish or English. We have few questions about the precipitation patterns. Can you tell us a little bit about how the precipitation patterns went along the years that you present, what the relation with dengue cases, and how did you see that the precipitation patterns were altered by climate change? If you can tell us a little bit about it.
Yeah. Through the years from the 90s, we have a lot of change related to climate change. And at the first time and the first period, we have no problem with that. I said before the 20th century, we don't have those problems. We have two seasons so good defined. We have just one increase of the cases with the increase the precipitations, and it was the time that we had our winter, and that now is we name rainy season. After the 20th century, we start to have a different issues about the climate, and sometimes it's very hot, and sometimes we are just float everywhere, even in the low areas, and we start to see how the increases, they were more extent, or was the highest the highest cases were in different season or in different moment. At the beginning, we have the high cases by epidemiologic surveillance week 29 or 30. After the 20th century, we have a different weeks, and sometimes we have in two periods. And the period that we have, we always expect to have a high cases, and the other one that is not related with precipitation. Instead, we're in dry season. No raining any time. It was really hot and dry. And right now we don't have so clear the weather. Sometimes it's really hot, and sometimes it changes in the same week or even the same day with a lot of rain. And then we spend 2-3 a week without rain. And so we have the opportunity to give the opportunity to the mosquito to change and have the ability to adapt in different kinds or different kinds of areas, geographic areas, and highest cities. So our vector is really cover all the country. It's not like the beginning only in the lowest cities, and now we have all over, and we have all over epidemics, even in places that they are high. It's not related with flows, but more for temperature and precipitation.
Thank you, Catalina. Now a question to Dr. Gudo. Dr. Gudo, concerning vector-borne disease and climate change, do you feel that the increase in malaria and dengue are attributed to more to temperature, moisture, or a confluence, or the ability to regulate and treat to extinguish the Aedes aegypti species?
Yeah, thank you for the question. Well, I think it's a combination of the factors. So I think there are implications from you have more water, you have more floods, you have more breeding sites. So the mosquito has more place to grow, the larva has more place to grow. I think from one side. From another side, it's well known that the increase in weather, they also create, the mosquito are more adapted for the replication, for multiply. So that is the second component. There is the side of human behavior. So because our behavior is changing as well, and some of the change in our behavior are facilitating the job for the mosquitoes. So on one side, people, because of it's getting warm, people stay more often outside. So instead of indoors, in some places there is more resistance because people are getting tired of adhering to the strategy for prevention of bite of mosquitoes. So today it's much more difficult to convince people to adhere to IRS or to indoor residual spraying, bed nets, because there is a kind of fatigue for that. So it's part of our behavior. So we have to find ways for that. So I think it's a combination of factors, but definitely the sole increase of the floods, the frequency of floods per se, it's enough. We have seen this in Mozambique, where there are places where malaria are being controlled because of the use of different interventions, but the recent increase of flooding as being a setback for that progress, because there are many more breeding sites for mosquitoes. There are places, even Maputo surroundings, where I'm living in the capital, it's a urban area. There are in some urban areas or suburban areas where in the previous years, when in the raining season, you see that few days after the raining, the water has been absorbing by the sand. So you don't see, you see water staying there for months. So, and then it's create a breeding site that did not exist before. We have done modeling analysis for Mozambique. We look at the trend, historical trend, I think on 3 decades of changing in precipitation and the temperature versus cases of malaria. We did for malaria and for diarrhea, but your question is on mosquito-borne. Looking at malaria, on the malaria cases that are reported through the DHIS2. And we found that there is a direct relationship between the increase of the temperature, increase of precipitation of last 3 decades versus the increase in malaria cases. So yeah, hope I have been able to answer your question. Over.
Thank you, Dr. Gudo. Another question for Dr. Catalina Ramirez. Catalina, you were talking about the municipalities and the communities' interaction in the process when you were doing field epi. Could you tell us how is that interaction with them, how that worked, what was the response of the community, how they get involved, engaged, and how they help with the method?
Well, at the beginning, it was just limited with doing just information for the population, and now we have and by that time the municipation and the organization were just given money to do our work, and health minister is the same way. Here we have a different kind of health systems. The Social Security is the only that give attention, and the health minister is the one that do the vector control. But that time just was an issue about money to do stuff for us, that we do the patient and the public service, and for the minister to do the control and vector control. Right now, through the time that they involved with different jobs. Besides financial issues, they do different kind of stuff, but doing they were picking up some things that the people don't use, and they can through anyway, and to avoid to the population doing that, because they throw it anywhere, field, river, and all over. So the municipation were incorporated inside the activities, their activities, doing recollection or of the all kind of material. And we start with a strategy about recycle and doing a different kind of approach with the population. And the municipation, it was more interest about the environment management. So and even they start to have office about the environment management, and they start to work with us doing campaigns to recollect trash that it can be recycled, and trash that have to, we don't have to wait to match. And the other organization incorporate the chance to do all the stuff that we can do it, even the municipation, some organization help us to measurement all the tire, and we burn up the tire and as a fuel to our as a fuel of make some cement to make houses and all the stuff. So they have a big factory that use all the tires that we recollect, and we put it over there. They use it to burn out for the machines who are doing the material to build up houses. And other ones like the communication area, all the networks of communication start to doing campaigns to recollect in one point in different areas of the country, all the material that is it can be recycled. I don't
Thank
know
you.
if, okay.
Go ahead if you have anything more to add.
Well, and about malaria, we have a different leadership from the community that help us to identify people that is having fever, and it could be have malaria if they come from the north of the country. Thank you.
Thank you, Catalina. Dr. Gudo, you tell us that you were doing research and you were doing some modeling with the meteorological variables to see how they affect the vectors. Did you do any kind of research to see if Aedes albopictus has a more wide distribution in Mozambique besides the place where you found it already and you have mapped it?
No, this is the only one. This is the largest ever we have done. The problem in Mozambique is that this is not part of routine surveillance. So routine surveillance for Mozambique for mosquitoes is largely for anopheles because of malaria. As I said, malaria is every part in the country. So this is the only we have done, is the one with larger number of sampling places, sampling sites that fit it to disease. So because there is no vertical program to combat disease, let's say the problem is that it's being neglected. So it's not only Mozambique, I think I would say mostly in sub-Saharan Africa, and the focus has been on malaria, and then less on arbovirus, despite the trend burden is rising, but there is the problem is if you compare, so you have 10 million cases of malaria with the country report per year, 400 cases death of malaria, but it's known that there is heavy in the reporting, and then I think WHO has been trying to I would say to estimate that there are around 10,000 deaths of malaria per year in Mozambique, based on estimation. But if you compare with arbovirus, we have not heard about any death. Obviously, there are people that might die, but because of lack of diagnosis, they are not being reported. They are misdiagnosed as malaria or other febrile or unknown case. And there is less programmatic interest, prioritization, and funding. So funding definitely is, prioritization is an issue. So indeed, what we are doing, we are generating evidence to showcase that please don't forget malaria, but please start also looking at arbovirus because they are coming. They are coming slowly, but if we don't take in account that they are coming, so we will have to face consequences in the future decades. Over.
Thank you, Dr. Samu. Okay, we are almost on time, but we'll do some more questions. There's another question here for Dr. Gudo about the training, the lab training. What kind of lab training do you include in your FETP? Could you tell us a little bit?
Yeah, sure. As I said before in my prior answer, that there is low awareness in Mozambique. It's increasing now because of those set of evidence on arbovirus and Vector-borne zoonotic disease. And then what we do is that we want to, they are not being trained to be expert on lab component. What we want is them to be aware that there are diagnostics for that, serological, molecular diagnostics, What are challenges? For instance, for serological diagnosis, it's important to take into account that there is cross-variation. So you have to be cautious when you interpret results from your serological testing, and then that the molecular is good one, but molecular is face a challenge because the variant is so short. So you have to pick the sample on the right time if you want to get a positive sample. The challenge that they have that they are, because this is RNA virus, you know, RNA is easily degraded. So in terms of sample storage, cooling, it's important that this be done properly so that you have a good sample. And then they understand that where they can have the test, so we are able to test for those pathogens within our reference labs, but this testing diagnosis are not available on the primary health care. It's important then to be aware. There are some rapid tests that are being used, but we share with them the challenges of using the rapid tests. So we have done some comparison. So of results from ELISA, PCR versus rapid test, so that they come up at the end of the module with the foundation, the basics of diagnostic of arbovirus. What exists, how it should be interpreted, how reliable they are, the difference between them, and then where they are available in the country and why it's hard to get them available in all primary health care. The same we have malaria. Malaria, we have a vertical program. It's funded by Global Fund, it's funded by PMI, it's funded by other donors, so it's different. So we go around those times and we want them to, because some of them, they will become director of public health and future director of medical chief officer, they will become provincial medical officer. When they get that level, so they are more aware on that. There is a need to invest more on those diseases, and then at the end, they at least they are more aware on the arbovirus and other zoonotic disease. Over.
Thank you, Dr. Gudo. Dr. Catalina Ramirez, what is the response rule of field epidemiologists in vector-borne disease? The bulk of the public health work evolved around surveillance and prevention control intervention. Do field epidemiologists investigate cases aggregates? That's the question, if you do.
Okay, yeah. Well, I didn't present it, but because the time, but we have surveillance system since the community or the primer the prime primer nivel, the lower system of the service of health, that since that level we have different people that is prepared since the 90s, I think, because the investigation, that paper that I showed, it was made by the FETP members, and they belong to the surveillance system, and in each primary health system of her health service is a people that is a one person that leadership, that all the attention of these cases or the other cases or any surveillance system. And they have since a basic preparation about field training, to the highest level that is formal education about epidemiology. So we have our network of the epidemiologists that they do their work related to the level they are. And so we have all over the country people prepare from FETP field training to do the work that we need to do in attention, investigation, all the stuff. Even to participate in a situation as a natural disaster, natural earthquakes, flows, and any kind of the thing that is related with human health and all the issues about health system.
Okay, thank you. Thank you, Catalina. Thank you, Dr. Eduardo Gudo. And thank you also to Manfred Malamia. He has some trouble, but we will share with all of you the presentations later. Also presentations from Catalina and Dr. Gudo as well. Thank you a lot, everyone, to being here in this webinar. We hope that you have a good time and you learn a lot as I did this morning. And thank you, everyone, for the work that you are doing in each country.
Thank you.
Bye-bye and see you next time.
Okay, thank you. Bye-bye.
Bye-bye.